Shall we move to another subject, another thing? At the end of this conference, I know that everybody is tired, and I hope you listen to listen well to Dr. Kristen from States. I hope this subject will you like it, everyone. Dr. Kristen will talk about women in surgery. It's a very nice subject to listen, I think so.
Yes, well, thank you very much for the introduction and for the privilege of talking about this topic. You know, as I sat here in this room yesterday and looked around the audience, I thought for a brief moment, maybe I'm in the wrong room, maybe I'm a little bit outnumbered to come up here and talk about this. But over the last day and a half, I've decided, no, I'm in exactly the right room to talk about this. Because this is how we change our paradigms, and this is how we begin to shift the needle when we allow women surgeons to be recognized, to talk, to present at international meetings. So for that, I thank you all for this incredible privilege. I do have to give you one disclosure. I am, in fact, a woman surgeon. So that's the only disclosure I have related to this. But I also have to tell you that I chose to talk about this topic because I work in the company of some incredible women surgeons, all of whom have inspired me and have taught me a tremendous amount about some of the bias and the discrimination that happens on a daily basis. So if you've not seen this talk or heard Dr. Greenberg talk, I highly encourage you to look at it. It's available on the internet. This was her presidential address from 2 years ago from the Association for Academic Surgery, where she talked about sticky floors and glass ceilings. And it was a tremendously educational talk about the inherent and often unconscious bias that women surgeons face. And so that should be recommended viewing for pretty much any surgeon, but especially for surgical trainees if there's any in the room. And that was one of my first introductions to some of the problems that women in surgery face. My second one came about with this. And if any of you have seen this cover, this was a cover of the New Yorker magazine several years ago that demonstrated 4 women surgeons operating on a patient. And this became tremendously popular among female surgeons. We found something that we could identify with, and one of my partners at my institution actually tweeted a picture of 4 surgeons recreating this. And then all of a sudden it went viral. And women surgeons across the country and across the globe were retweeting this and taking pictures and found something that they could identify with. And before we knew it, we had hundreds of pictures from every country in the world of women surgeons and women anesthetists and women physicians showing their pride in what they do and searching for representation. Because as you can tell, if you can't see it, then you don't necessarily know that it's there. And we found women surgeons all across the world relating to this challenge. And so those are 2 examples just from my own institution that have shown me the power of women in surgery. So where do we go and where have we come from? If we look at the original figure on this graph, it started in 1980, and 91% of general surgeons were men, 9% were women. But if we follow this along, it shows from then to 2015, a tremendous increase. We've got about 41% women in general surgery now and 59% men. So we're starting to move that pendulum. And in most specialties across the board, we are seeing an increasing number in women. However, surgery still lags behind a lot of the primary care specialists. And there's the numbers that we settle out in 2015. So 41% women, 59% male. And I will disclose that this is essentially all United States data that I'm going to be presenting today. So we're starting to shift the balance a little bit, but we're certainly not there yet. When we look at salary data, women on average earn about $50,000 US dollars less per year being employed as a full-time general surgeon than their male counterparts do. Salary discrepancy data is not exclusive to surgeons. Salary gender bias occurs across all specialties, across all fields, even outside of medicine. So in this figure, you can see that the darker blue lines represent the average female salary in a country, while the lighter blue lines represent the average male salary. And this is true from low-income countries to high-income countries. It's certainly not limited to the US or to surgery. So overall, women make less money for doing essentially the same job. Women surgeons are more likely to never marry, They're more likely to be divorced, and they're less likely to remarry. Why this is, I can't give you a good explanation, but that's the data. The pink lines represent women, the blue lines represent men. Women, however, are more likely to work full-time as a general surgeon in the United States. 95% of women work full-time, only 5% are part-time. 93% of men report working full-time, only 7% report part-time. Women physicians are more likely to experience burnout, and this is particularly true in surgery. And while we can look at this figure and see that the red lines represent women with a pretty appalling 59 to 58% reporting experiencing burnout in 2015 and 2016 alone, I think this brings to light another important topic, which is how horrifyingly high these numbers are for all surgeons. Men and women alike, since 2013, have had 40% or upwards of their participants reporting that they're experiencing burnout. So this is a tremendous problem, and that in and of itself could be a complete separate topic that I could talk to you all about. Now let's talk a little bit about women and having problems in the operating room. There's certainly a gender bias in healthcare design, and in many designs, in fact, because I can tell you that about half of you guys can't see my face. Probably need to be standing on a box. This podium was not designed for someone of my height. In the operating room, however, women are often younger, shorter, smaller glove-sized, and have fewer years in practice. So let's look at this data. What percentage of women, compared to men, receive treatment for hand injuries? Almost 30%. Almost 75% of women experience shoulder discomfort associated with laparoscopic surgery. I can tell you from personal experience that's absolutely true. Now, is this simply because design was not made for women? That we don't know. It may be that women are more inclined to report this, but I can certainly tell you that we've all experienced some of the ergonomic challenges in laparoscopic surgery. Personally, speaking to the gender bias in healthcare design, I can tell you that to this day, I still cannot fire a laparoscopic stapler with one hand. I wear a size 6 glove, and it's really challenging. I also can't operate a colonoscope with one hand. So many of these things were not designed for the entire workforce to use efficiently or effectively. And how we fix that could also be a completely separate talk. Let's look at some of the academic components of women in surgery. Even though when we see on the left of this figure that women and men are about equal as matriculates into medical school, most places in the world now it's almost 50-50. 50% of students are women, 50% are men. That stays the same for graduates of medical school. And we start to see a divide in residency, not surprising for surgery especially, but we see a drastic and steep, sharp decline when we look at women in faculty positions and then moving into leadership positions. So associate and assistant professors rarely make it to full professors for women, are even less frequently tenured or become department heads or deans. Even to this day in the United States, we only have about 25 to 30 female chairs of surgery out of several hundred departments. So we're making slow and steady progress, but as I think you can see throughout the recurring themes of the talk, we're not quite there yet. Unfortunately, there's a tremendous amount of unconscious bias. Women physicians in general are less likely to be introduced by their professional title at grand rounds or at any speaking engagement. 72% of the time, a male doctor is introduced as Dr. So-and-so, Professor so-and-so. Only 49% of the time were female doctors introduced by their professional title. And this was data collected from 320 introductions of grand rounds presentations at the Mayo Clinic. Women are also significantly less likely to receive large grants or particularly NIH grant funding. And that leads to some of the data that we've seen recently suggesting perhaps applications for grants, applications for residency, and even faculty or promotion packets should be blinded and not have names associated with them. If we go way back, several decades ago, a brilliantly performed Harvard study demonstrated tremendous bias in the Henry and Harriet debate, where 2 job resumes were submitted with the exact same profile, and the only difference was the name on the application. And the male application universally wanted to be hired. The female application was considered not appropriate. And the only difference for the same job was the name listed on the application. So perhaps most importantly, let's talk a little bit about clinical work. We're all surgeons here. We're all interested in taking care of patients and how we can do that better. So can women do that? They can absolutely do that. Overall, they are less likely to have patients die or be readmitted in a 30-day window, and this particular data is for all women physicians, not simply surgeons. So at a minimum, we can extrapolate from this that outcomes are equivalent, if not a little bit better in certain situations. Female physicians looking at 1.5 million non-surgical hospital patients on average had a lower 30-day death rate and a lower 30-day repeat hospitalization rate. So clearly the capability is there. From the surgical standpoint, many women, physicians or surgeons, are less likely to have patients die within 30 days of surgery. And this was a fairly well done comparative of post-op outcomes looking at truly a population-based and matched cohort study that was published back in 2017. This perhaps though was the most concerning data that I have seen in research relating to gender bias and discrimination against women physicians. Women surgeons were significantly more likely to lose referrals from primary care doctors after a patient death compared to their male counterparts. If you look at this figure, what this is showing you is male surgeons on the left and the continued pattern of referral compared to female surgeons on the right with a decrease in the referral patients. So women surgeons were judged more harshly for the same exact complication than their male counterparts, and they lost referrals, which makes it hard to succeed and hard to build and advance a practice. And this goes to show that any one of us can have complications. No surgeon is excluded from that. However, we have to certainly be aware of the unconscious bias that we might be facing in this. What about trainees? We can certainly talk about women in the workforce and in the faculty surgeon positions, but what are we doing to fix this? It has to start at the trainee level. It has to start at the beginning of the pipeline. Unfortunately, we see mostly similar data for female surgical residents. Female medical students are significantly more likely to be asked illegal questions in the interviews, and in the United States, it's illegal to ask about marital status, plans for children, anticipated time off from residency. However, those are still, in 2019, commonly asked of female applicants and not of male. Women medical students are more likely to report gender discrimination or harassment, and they're significantly less likely, unfortunately, to go into surgical specialties, despite initially expressing interest in that, which means that somewhere along the way, we are failing our female medical students and residents, and we're not getting them into surgical careers despite them being interested in that. So the most important slide from the talk, what can we do about this? We can break this down into two different categories. Systemic interventions, which are critical but often much harder to obtain. We need to look at things like salary transparency. My institution just did a complete salary overhaul where several of our new female physicians that were surgeons that were hired received a significant raise because it turns out they had been hired for the exact same job, lower than several of the male physicians that have been hired in the last few years. So transparency is a huge, critical thing we can begin with. Blind grant and manuscript review. You can start to eliminate some of that unconscious bias if you eliminate some of the things that are associated with that. Blind promotion packet reviews. Equal leave policies, family leave policies. There are many, many countries around the world that are far ahead of the United States in the way they care for all of their workers hoping to have families. Objective measures of success. And education, particularly importantly, in programs on implicit bias. I now sit on our medical school admissions committee at the University of Wisconsin, and every year we go through a 3-hour training on implicit bias because the most important thing for anyone in this room is to recognize that we all have biases. We all do. Every one of us is guilty of that. So how do we address that at the individual level? The first and most important thing is amplification. If you know a woman medical student or a woman surgeon who's doing phenomenal work, continue to amplify that, support that person, allow them to go and speak at international meetings as my colleagues have done for me. Acknowledge that sometimes we have microaggressions and we may not even realize what we've done or what we've said has been offensive to someone. Importantly, we have to encourage and sponsor women in leadership positions. Putting people out there is critical. Of all the panels that we've had at the Association for Academic Surgery recently, only 1 in 5 of them has had a female surgeon on that panel, and we know there are more qualified surgeons out there that are women. Have equitable negotiations. Be a mentor. Everyone in this room has the capacity to serve as a mentor for a young female medical student or resident that's looking to be in the positions we're all fortunate enough to be in the future. Establish women's groups that support women in surgery. And again, as we've already started to allude to, most importantly, admit and acknowledge that we do have a gender bias. We have a problem that can be fixed. So I would end with asking the question, are we there yet? I don't think we are, but I think we're getting much closer. This is a picture of the women physicians in my department of surgery from 2 years ago, and I'm proud to say that we at the University of Wisconsin are at about 50% female surgeons. So we have a tremendous group of supportive women. We have supportive male counterparts that allow us all to work together and take the best care of our patients. Women represent 50% of the population. There's absolutely no reason that we shouldn't have them representing 50% of our workforce and of our surgical workforce. So most importantly, I want to thank you all for giving me the privilege to talk about this, to recognize this as a problem and hopefully move forward and get us to the point where we are on equal ground. Thank you very much.
Thank you, Kristen, for your representative and comprehensive talk. I think I have a comment myself.
Yes.
Okay. I think the problem is the problem of women surgeon. I think we have to focus on the three items. First is the gender bias, as you said. I agree with you. There is a gender bias for male, for salary, for everything, for kind of operation, so on, so on, so. And next is the culture. I think the culture in some areas is very important, because in the Western, it's completely different from the Eastern countries and the Middle East and the Islamic countries. It's quite different. And the third one is the patient preference, the patient acceptance and the preference to be treated by a surgeon, woman surgeon. I think should be changed in mind. The mind should, you have to change the mind of the patient himself.
Absolutely. That is something that I encounter probably every week in clinic, is after spending an hour with a patient explaining everything we're going to do, you know, name badge clearly visible. They've known who their appointment is with for months, and after all of that they say, so when is the doctor going to come in?
Yes.
And I smile politely and I say, well, I'm glad you asked that. I am the doctor, and I will be performing your surgery.
I agree with you that we have to encourage the women groups everywhere to be a surgeon. And we started to collect women in Egypt here women surgeon started to collect, and I hope that we could succeed to collect many women surgeons here. I think it is around all over Egypt. I think it is around 100 or so maximum. 100 women surgeons or so. But I see in Saudi Arabia and Jordan is too much increasing. In Saudi Arabia and Jordan, against our brain knowledge or brain or in Saudi Arabia, exactly, specifically, many women surgeons in Saudi Arabia, and they worked in the hottest area, the emergency and something like. Here I ask you a question: shall we reserve some specialties in general surgery for women? May encourage the woman to be a surgeon?
I don't necessarily think that reserving spots or recommending particular specialties will encourage women to pursue surgery. I think there are certain specialties women may inherently want to pursue, but I think across the board women can excel in all fields of surgery. I do think there are certain areas where patients actually very well may prefer seeing a female surgeon. In our country, it's very common for a female patient to request and want a female breast surgeon, or a female patient with a colorectal issue ask for a female colorectal surgeon. But as you've alluded to, culture change is incredibly slow and takes decades, and I think we're just beginning to make some of the first steps to allow people to realize that women can do any field of surgery that men can do, and we're slowly going to get there. And I think the first step is allowing our students and our residents to see that there are female surgeons out there that are doing it and succeeding, and the way that we've done that and that you guys have supported that is allowing someone like me to speak about this topic. So I think you guys are to be applauded, and you're certainly ahead of several of your contemporaries.
So I hope we can succeed to collect and to gather here some surgeon you can
I think, Dr. Christine, at first, do you think that the legislative authority has no role in this problem, that's one question. The second thing, here in this country, the OBGYN male doctors are not treated well, and the females here will prefer the female OBGYN than males also. The third thing, to really get the public confident in female doctors, is that you have to exemplify those ladies who did breakthrough in medicine. Because over the years, over the last 100 years, nearly all those doctors who made progress in science, they were males. And so you need to exemplify those ladies, doctors who really did a breakthrough in medicine.
Absolutely, you could not be more right. So we are all standing on the shoulders of the people that elevated us to this point. That's the only way we're going to reach the glass ceiling is the people who came before us. And I, as I said, am tremendously fortunate to work with some of the thought leaders in this particular area of surgery. As for your first question, I don't know if there's a role for legislation in this. I think that example is the most powerful tool that we have, and even in the United States, the NIH has started to say for some of their conferences and panels that they're no more manels. We're not going to have a manel. We're always going to have female representation on the panel, and that's a very great first step, but we obviously, it's multifactorial and we have a long way to go. And as you also alluded to, I think the bias works both ways. So recognizing that there are specialties in which men may be discriminated against, and acknowledging that, and the way we start to fix that is to talk about it. So I thank you for bringing that comment to the table.
Dr. Dr. Dua is a colorectal surgeon. There's a lecturer of surgery in many universities. Okay?
Muhammad, merci, Dr. Christina. I would like to thank you for this lecture because you touched many issues that we already experience. All these issues we experience, beginning from the bias to the heavy disturbance of laparoscopy and shoulder dislocation. Public confidence in female surgeon, in my small experience, is easy to be gathered when public males patients saw a good job and a good operation and a good interest, they get confidence and no problem in that. I am from Upper Egypt, colorectal. When I do my job better, even male patients ask for me to do their operation.
Yes. And
the item is a good job and good care for the patient. The patient don't have no bias. The bias from other sides.
Agree with you 100%. I think that the most rewarding thing for me at the end of the day is a job well done and a patient that is incredibly satisfied in the care that I've given them, and maybe even in the end that I have changed someone's mind. Maybe somebody came in with a bias and leaves with
this is not difficult.
Less bias. So I agree with you.
Thank you.
Thank you.
Muhammad Salim.
Just a couple of comments I'd like to say about doing practicing surgery. We know very well that statistically 50% of medical students in the United States now becoming female, so the ratio is there. In general surgery is about the same, 50-50 I can say. The issue that you raise about salary or compensation difference, I think it's a businessman decision. It's not surgeon colleague, not physician based, that probably prorate the time off that female physician
Might
can
be
take
close.
off.
Close the mic.
I think it's a bias from the business people toward women regarding their colleague for men, time off, vacation time, delivery, family leave, this kind of stuff. So they calculate it as a prorated to some extent because 15,000 difference is negligible to the state. A couple of things also about referral and the loss of the referral over a period of time. I think that's patient confidence not related to other surgical colleague in your community or anybody. So if the patient is allowed to choose, they choose based on the reputation of the surgeon. So it's a community issue. It's not a surgical field issue, not physician-related issue. So I think that you have to earn, physician has to earn their credibility in the community as much as anybody else. From a cook to a hair dryer dresser to designer to anything. So it's hard for the community to accept in certain area more than others. So it's really nothing to do with our colleague in surgery or the medical community as a whole. We encourage female physicians. We like to work with women, but the problem is the community acceptance, like what the colleague said. In Egypt now, the female OBGYN is taking over the job. For a long period of time, they spend years and years, they still don't have the confidence to go to a surgeon female because of physical competence, not anything about the medical. So there's
something to think about, but I would tell you that the data presented from, particularly the article showing referral decrease, is directly correlated to PCPs. It has nothing to do with patient data.
You mentioned 71% of the female go to PPG, right?
I'm sorry?
71% of the state going to primary care. So the referring coming from your colleague physician. The female to female.
Yeah, it's both women and men at the primary care level, unfortunately. And so I think just educating that there's a difference.
Does that reflect the patient request or the physician request?
These are new referrals to surgeons from the referring physician, not the same patient, unfortunately. So I think it shows.
I know because I'm a general surgeon too, so I don't have who made the decision, the primary care or the patient himself who made the decision.
And we see both, certainly. I see patients that have direct referred to me, but I also I have many primary care doctors that will refer directly to me or directly to my partner or to our group as a whole. But I think that study was very interesting because it was the first time that we did start to see perhaps that's one example of true unconscious gender bias.
So. That's correct. Thank you very much.
Okay. Thank you so much, Dr. Christine.